Moving towards our fourth session, anemia in CKD tends to primarily involve functional iron deficiency. To take on management of anemia in diabetic kidney disease, I will call upon our next eminent speaker, Dr. Arup Ratan Dutta, Director Nephrology, Fortis Hospital and Kidney Institute. And to chair this particular topic, I would like to invite Dr. Tanima Das Vettacharya, Consultant Nephrologist and Transplant Physician attached to Narayana Super Specialty Hospital, Howrah. Ma'am, please take your seat and introduce our eminent speaker.
Hello, good morning everybody. And sir, it's an honor to chair a session which will be delivered by you. And thank you for this privilege. Professor and Dr. Arup Ratan Dutta is the Director of Nephrology and Transplantation, Fortis Hospital, and everybody knows him. And he is well known not only in India, but as well in the international forums. So without much delay, I would ask sir to start the deliberation.
Thank you very much. I thank the organizers, particularly Dr. Bishwai and Dr. Mridul Bera for inviting me here. I understand this program has been going on for several years. Bishwai was just filling me on this. So I think many congratulations, and this is, I can understand this is a very successful conference already. Now, two clarifications here. Firstly, I understand this is a diabetic, this conference is focused around diabetes, but what I'm talking is not necessarily about diabetes. On the other hand, the majority of our work for a nephrologist, 70–80% of our patients are diabetic. So whatever I speak is not out of relevance here, because any CKD, 80% of all CKDs perhaps from diabetes in any case. So, as you know, that CKD is fairly common. The new incidence is about 2 lakh cases a year, and the prevalent pool is really huge. Now, if you see the patients who are in CKD 3, 4, 5, that number is clearly several lakhs, 30–40 lakhs in our country. About 1/3 of this would be requiring some anemia management agent, because anemia is very prevalent. Now, what you need to understand here, that anemia is a risk multiplier. So what do I mean by that? Like you have, somebody has diabetes, he has a little risk of early death. The same patient gets hypertension, so his risk is multiplied. The same patient gets CKD, it gets multiplied even more. And he gets diabetes, hypertension, CKD, and anemia, the risk gets multiplied many times over. Similarly, you may not have all the 4 components, diabetes with anemia, risk multiplier, hypertension with that, again a risk multiplier. So you need to address anemia, and so long for the anemia management, we had few options. So in the 1950s, 60s, 70s, there were practically nothing. In the end 80s, towards the early 90s came erythropoietin, and in India also it came around the same time. I happened to be doing the first trial of erythropoietin in India. The brand was Hemax at that time, from Hindustan Antibiotics. It's not available anymore. So, and erythropoietin was the mainstay of anemia management until lately, for the last 30 years, 40 years almost now. So there was darbepoetin, which is again a long-acting form. The basic physiology was the same. And then came many iron preparations, because simple, I will explain that in a while, that only erythropoietin is not always enough, you need iron also. Then post-COVID, we are giving the new agents, which is the focus of today's talk, is the HIF-PHI, that is the hypoxia-inducible factor, prolyl hydroxylase inhibitor. So I will explain the physiology shortly. So now we have erythropoietin, we have iron, and you have the HIF-PHI. So there are 2 major factors in erythropoiesis. First, you have the stem cell, and the erythropoietin stimulates the maturation of that into the burst forming unit, then the colony forming unit, and the effect of erythropoietin actually stops there. It becomes a pro-erythroblast, and after that it incorporates the iron into the heme. Now, you must understand here that no iron, no hemoglobin. You can put any amount of erythropoietin, but if the body has no iron, And by no iron, I mean there can be iron in the body but not in a ready supply, like you have money in the fixed deposit bank but not in your savings account, you cannot withdraw that immediately. So it must be, iron must be available in a available form. So you need erythropoietin and you need iron. So what I tell my patients to explain to them that when you build a wall, you need the bricks and you need the cement. If you give cement only, the wall will not be built. And you need them in a proportion on a continuous basis. So same here. You need erythropoietin for CKD patients and you need a parallel supply of available iron. No iron, no hemoglobin. So we know that the erythropoietin comes from the kidneys. Everybody knows that. And we know that hypoxia is a stimulant for the kidney to produce that erythropoietin so that there will be more red blood cell and the tissue hypoxia will eventually be mitigated. What was not known so far is that what connects the hypoxia with the EPO, with the kidney. Just hypoxia, and there is hypoxia and the kidney starting to produce it. So what is the missing factor there? That missing factor is known as the hypoxia-inducible factor, and the HIF pathway, the discoverers of the HIF pathway, Ratcliffe, Kalin and Semenza, they won the Nobel Prize in Medicine in 2019. Of course, the work was done much earlier than that. So this is the focus of today's talk, the HIF pathway, hypoxia-inducible factor. So what happens here? What is HIF? Now, give a little time here, and so in normoxemia, when there is normal oxygen, the hypoxia-inducible factor, it exists in two forms. One, the hypoxia, the HIF1 alpha and one beta. The 1 beta resides within the nucleus, the others in the cytosol. The HIF1 is degraded in presence of normoxemia by the prolyl hydroxylase, which is at the top of the thing, here. If there is normoxemia, the HIF is degraded by the prolyl hydroxylase. Now, HIF1 alone cannot work. In the stages, when there is hypoxia, there is no oxygen to degrade the HIF1 through the prolyl hydroxylase. Prolyl hydroxylase requires the oxygen. If there is no oxygen, then the HIF is free. And the HIF is free, and then the HIF can get into the nucleus, combined with the 1 beta, HIF1 alpha combines with the 1 beta, and then sits on the DNA to produce all the after effects, which is angiogenesis, the increase in the EPO, and a few other things which are coming to it. So in normoxemia, HIF is inactivated by the prolyl hydroxylase. And in hypoxia, the HIF pathway is kind of released. So if we can inhibit the prolyl hydroxylase, it is going to work as if there is hypoxia and the EPO will be stimulated over there. Now, in addition to that, in addition to stimulating the erythropoietin from the kidney, it has other effects also, which is increasing the absorption of the iron from the intestine by dropping the hepcidin, which inhibits it, increasing the ferroportin, which will enhance the absorption of iron, and it increases the iron transport into the bone marrow cell, makes it more available, which is the second step. So increased EPO, increased endogenous EPO, you're not giving EPO from the outside, it increasing production by inhibiting the inhibitor, and you're also making the iron more available. So if this is sounding too complex, you only need to remember two things. So it's a mimicker, so that this drug is activating the HIF pathway by inhibiting the inhibitor, but the drug is the inhibitor of the pH. So it is basically mimicking hypoxia. The HIF inhibitors mimic hypoxia and it also makes iron more readily available. So why do we need another molecule? We had erythropoietin, we had iron. Why do we need another molecule really? So primarily, EPO responsiveness is not 100%. And sometimes the EPO responsive can go hyper. You get hypertension, which is extremely common. And sometimes in the dialysis patients, they often have a very, very fluctuating blood pressure. Very often the blood pressure goes more than 180, 200. and we are unable to give the erythropoietin. And the erythropoietin is actually causing the hypertension, and you cannot give that, so it's a complex thing. It can increase the blood volume, it can increase viscosity, and if the hemoglobin overshoots, then there is a high incidence of strokes and high incidence of fistula failure. So there is a sort of an unmet need over there. And you need a more gentle molecule which will not overshoot much, and it will not really make you give supraphysiological doses of iron or supraphysiological doses of erythropoietin. So HIF was the answer. And so this is new in the market, but we are very happy with the initial results, and only the next 5 years will tell where we really stand. So what are the clinical benefits? So the theoretical benefits are many, like it is oral. It increases and maintains hemoglobin levels fairly effectively, as you'll see. There is an increase in endogenous EPO, and it regulates hepcidin, which actually decreases the iron absorption. And by regulating the hepcidin, it increases iron absorption, and which is not influenced by inflammation. There is no risk of hypertension. It also lowers cholesterol to some extent. It's not a very great effect, but it does to some extent. Mostly, it avoids very, very high EPO levels. When you are giving an erythropoietin from outside, it goes in thousands of units. So you are actually trying to achieve supraphysiological dosages. And of course, you avoid certain side effects also with IV iron. You need some iron also over here, but maybe the requirement is a little less than what you need with the EPO. So there are two studies basically which brought this molecule into the market. One is the DREAM-ND study and the DREAM-D. ND is in non-dialysis and D is in dialysis. So I'll not go into the details. It is mostly of interest to us who are practicing this specialty. By and large, desidustat, which is the molecule that is available in India, there are a few more, but desidustat is the only one that is available. The study is on desidustat. It was shown to be non-inferior to darbepoetin in the treatment of anemia in patients with CKD who were not on dialysis. And you'll see the graphs in the next slide, and the safety was sort of comparable. You see that is more or less the same effect, so it is non-inferior. And on the iron metabolism, there may be a little benefit. There may be slight benefit over there. Importantly, there is no difference with darbepoetin. This is in non-diabetics. This is in non-dialysis. And on dialysis, again, it has been tested against erythropoietin, and it was shown to be non-inferior compared to erythropoietin in the treatment of anemia in the patients of CKD who were on dialysis. And the safety was comparable. So this puts this molecule firmly in place in the treatment of anemia across all the ranges, starting from non-dialysis to, into dialysis. Again, you see the same thing, same effect on the hemoglobin, and almost a similar effect on the iron. At least it is not worse, so one can use it easily. So how do we use the molecule? So it's used for, as you understand, is only used for anemia due to CKD. We don't give it in iron deficiency anemia where the kidneys are normal, because there are already physiologically the EPO doses are high over there. So no point in giving it there. It's only for CKD, just as in erythropoietin. There must be a reasonable amount of iron in the body. Ferritin level more than 200, transferrin saturation above 20%, and it is kind of ensured. You can give an oral drug, and if you're thinking that it's not working well, you can check the levels and then see. Normal B12, normal folate, these are kind of prerequisites for everything. You give it anyway. Now, of course, you give it to somebody who has got good oral adherence. A non-compliant patient will not take this drug also because it's a little more expensive than your standard tablets. But overall, the monthly cost is actually cheaper than erythropoietin or darbepoetin. It costs about $2,500 in a month, which is, I think, fairly moderate, I would say, in today's time. Now, this has been tried in people who had a EPO unresponsiveness or hyporesponsiveness. And I won't say that it works in everybody there, but it works in a significant percent over there also. And of course, patients in rural areas where there's a problem in the supply chain, and you're not sure whether the cold chain will be maintained with the EPO, this becomes a boon. It is just a tablet, and you don't need that. This is a new drug, so you try to avoid it for pregnant women. You try to, we don't know really actually what happens there. So it is kind of avoided as of now in pediatric patients, in the breastfeeding woman. Patients with proliferative diabetic retinopathy, because there is angiogenesis, this drug leads to angiogenesis, you don't know what's going to happen there. Same with the people with history of thrombosis and vascular calcification. Cancer area has not been studied so far very well, so it's kind of a query over there, but I think eventually this will also come up there. The starting dose is 100 milligram, and you give it 3 times a week, Monday, Wednesday, Friday, and is a 2-day gap, and it's very easy to give, and the tolerance is actually quite good. We have not had any major problem. So you don't consume mixed with the food, you just keep a little gap. That's the only requirement there. How do you adjust the dose? So long there is a little rise in hemoglobin, even by a gram a month. Let's say you have somebody's hemoglobin is 7.5, you've started it, and the next month it is 8.5. It's perfectly okay. So long it is rising a little and the patient is not symptomatic, there's no heart failure, there's no urgency, you can go slow about that. 1 gram rise per month is reasonable. And when you reach kind of to 12, you sort of cut back on the dose. I'll give you an example about the anemia management, and maybe this applies to many things in medicine, maybe allopathic medicine you can say. Sometimes we overdo things. Sometimes we try to solve things fast and it doesn't work out well. Let me give you an example. When I was coming, being Sunday, the roads were quite empty. So my driver, he found a stretch on the bypass, which was kind of empty. So about 200-300 yards, we could see forwards, there was no car, and there was a red light right at there. So he sped up. He sped up and the car went fast, and when he reached the red light, he slammed on the brakes. Now that acceleration was not necessary, and that braking was not necessary. He could have covered the distance in the same speed. So same with hemoglobin. If hemoglobin is 7, going up to 8, 8.5, you don't need to give blood transfusion. So long it is working, you take another 2-3 months, you'll be in a comfortable zone. So no sudden accelerations, no sudden brakings. Applies to many things in medicine. I just gave you one example here in anemia. So any other agents or any comparisons? There are 4 more agents, and a lot of things are being, suddenly has become a very busy area now. Roxadustat, we thought that this is going to come in India first. Valadustatin, Daprodustat, and Desidustat. But Desidustat came in the Indian market first. It's been available in the last 2 years now, and we are extremely happy with the results. But these will eventually come also. The minor differences in them in the molecular structure, pharmacokinetics, effect more or less the same. What about the side effects? Hardly any. We are using for last 2 years now. Bishma is here. Bishma will also second this. We hardly see any problem. In erythropoietin, we see hypertension. There's a bit of a peripheral edema, but that's also CKD patients almost always there. Some edema may be there. So nothing major there, both in the dialysis and the non-dialysis population. Particularly, we don't see the hypertension that we used to see in the dialysis population particularly. So it's pretty safe that way. So what has this drug really, what is the place of this drug today? For the majority of us, for the non-dialytic population, almost 100% of the prescription has become the Desidustat, almost 100%, unless there's a gross contraindication. And we find that the effects are also quite reasonable and without side effects. Patients like tablets, and it is not that costly also. In dialysis patients, if the anemia is, we would try to prefer the erythropoietin even now. But having said that, many of the patients in the last 2 years who have been started on the Desidustat are now entering the dialysis phase, and they're carrying this drug into dialysis. So I'll say my program, about 10-15% of the dialysis population is now on Desidustat already. And in the coming era, I would foresee that almost 80-90% non-dialytic patients will be on Desidustat or a HIF of some HIF-PHI, and about 30-40% patients on dialysis will eventually be having this. So it's just a shift in the market from one injection agent to a combination of injection and tablets for perhaps a large majority. Thank you.
Thank you, sir, and it was an excellent presentation. So we have seen you for years together and you inspire us, you teach us, so we learn a lot of things for you. That pothole and the car acceleration example was excellent. Only difference in our Indian roads, we have a lot of potholes. So we go through that potholes also before we accelerate. So two doubts with your experience, if you can tell us, that do we have a difference in anemia response based on different axes, fistula versus pump cath versus jugular? And second part is, since it's at a diabetic forum, does anemia correlate to hypoglycemia in the first use, first dialysis, the degree of anemia? And how can we take HbA1c, at what cutoff level we can take that HbA1c as a marker for control of sugars in these patients?
Okay, so the first one, what was the first question? Ask one by one.
First part was how different axes relate to the response of anemia management. Do pump caths have difficult resistance anemia?
So,
in that case,
so I would say that there should not be any difference based on the axis. For perm caths, there may be a little more incidence of infection, and the eclampsia, and you may be struggling with a bit. So therefore, those patients may be showing a little less hemoglobin. They're probably the sicker ones. Why did you make a pump cath? Because you couldn't make a fistula. So they are probably a more selected group. They're the worse off to begin with. And they are likely to have more problems. One is they are worse off to begin with. They have got a vascular problem. And the pump cath can also give rise to infective complications later on. So their level of chronic inflammation in the background, their inflammatory state, will be definitely higher than the standard good patient with a native fistula and clean patient. So that way, you're talking of two different subgroups of patients. Those are likely to have more anemia regardless.
so in such scenario, do you have any experience of using ESA with HIF together? Does they have any help in such scenario?
No, I have not so far used. I am actually, theoretically it may work, may not work. May work, may not work, because this is basically the production of endogenous EPO. And you have to understand that if you are, like what happens in cancer, they give mega doses of that. So if you're stimulating the endogenous, then the extra topping that you do with a standard EPO will be a very little percentage of that rise, because you are stimulating that in any case. I haven't seen trials doing that. There may be a place, who knows, but not as of now.
And second part, does the degree of anemia correlate to hypoglycemia in first dialysis, sir? Do you have any experience?
In first dialysis, no, I have not really read about that. But again, I would say it is a marker of how good your patient is. Whom are you really taking for the first dialysis? Somebody who is anemic and somebody who is not anemic, so obviously their general health matters. Somebody who is anemic probably is more advanced kidney failure also. And in first dialysis, we don't see so much of hypoglycemia. First dialysis is going to be a little less only. You're going to give it for about 2 hours. You make sure that he has a good glucose level to go around with. Give a little something to eat before the dialysis if you're worried about that. So I don't think that is a very major problem that way, at least in our program. But if your patient is sick, the sicker you are, the more this complication you will see.
Thank you, sir. So question, any question from the...
Arup, it's nice to hear you. I'm sorry I came little late, but I have a very clinical question. I have a patient who is having single kidney and diabetes, and the kidney has to be replaced. I mean, kind of renal transplant has to be done. Do you think these patients needs to be monitored more frequently? A single kidney transplanted patient doesn't have another kidney, and pretty young patient. So how do you look at these kind of patients as far as their anemia and other parameters are concerned? Is this same with whatever else you have been talking
Yes,
about?
it is more or less the same. Your new kidney is supposed to produce the erythropoietin. Now, sometimes there can be a little delay, but mostly within a month's time, the hemoglobin starts going up. By the time you're discharging the patient, the hemoglobin is showing a little rise. Sometimes we have to top it up with EPO, and we have been doing that over. Maybe I would not be using oxemia right then, but we would, cover it with EPO for about a few weeks in case post-transplant there's a delay in, the hemoglobin coming up. Again, you don't need to reach 13, 14 in the first month. So long there's a little rise, we are good.
Do you think the follow-up should be more frequent in these kind of patients?
For the transplant patients. For the transplant patient, there is a single kidney. Yeah, single kidney, double kidney, initially in the native kidney, it doesn't matter really. It doesn't matter. It's all the same.
Follow-up will be same.
Follow-up will be the same because, see, post-transplant, we'll be seeing them perhaps in 3-4 days interval for the first 2 weeks anyway. We will be doing the creatinine every 3rd, 4th day in the first 2-3 weeks. Then one weekly. So there is some built-in follow-up system in a transplant patient where they get to be seen, or the reports get to be seen maybe twice a week in the first 2-3 weeks. So that's covered in any case. And as I said, don't worry about the anemia part of it. So long it is not causing a heart failure or it's not causing angina or patient is incapacitated. If it's above 7, 7.5, we're good. We know that this is going to come up.
Right.
Thank you, sir.
CKD with dyslipidemia, phenofibrate in CKD with dyslipidemia, is there anything relation between that phenofibrate and creatinine high? Because I referred few patients to you, you at first stopped the phenofibrate.
That is okay. Okay, so it's a dicey area. So I'll just tell you, most of the patients where I stopped the phenofibrate is patients who had a normal creatinine and it went up after the addition of the phenofibrate. If it is a patient is taking phenofibrate, which is a very high triglyceride, CKD 3, 4, 5 anyway, creatinine is high, and then a little more rise, we really don't bother at this stage because, but sometimes you imagine, somebody in your family having a 1 creatinine and somebody gives phenofibrate, next time the report is 1.6. It is worrisome, and nobody knows actually. That area is, whether it is a lab interference or whether it is an actual creatinine rise, nobody knows. So with that rising creatinine, it is difficult to keep the phenofibrate on. Now again, you will see that you need a really high level of triglyceride to act upon. Just because somebody is 200, you don't need to really give something over there. In that case, I'm going to stop. Somebody who really needs it, his triglyceride has been too high, then I will accept that little rise. Now you have saroglitazar now. So we thought it is going to be, Kaushik is here, but even with that also the creatinine goes up. It was believed that this has got no rise in the kidney at that time when we started. But even that has been proven to have something. So for triglyceride is a difficult call. If the rise is moderate and you really need it, you have to accept it.
But the molecule itself is not nephrotoxic.
But you have nothing else really. I will ask Kaushik, what is happening to the old molecules, Gemfrivosdil, the Lopid that we used to give, are they still in the market?
Sir, just before closing, I would... Okay, sir. Please, go ahead.
We are talking something different, but this is important actually.
I guess it's more of pharmaceutical industry's interest. The Gemfibrozil and other agents which have gone out of vogue, they are pretty good. So far as the phenofibrate is concerned. But obviously there are interests to the pharmaceutical industry that also has to be respected. So far as phenofibrate induced rise in creatinine, which is not very uncommon, and I find in many patients, once you stop it, at least in 20% it remains elevated for some reason or other. It might have done some bit of damage in the kidney for some reason, though I also admit that it is not very high. The rise in creatinine is 3 times, 4 times, nothing like that, but it's only around 20 to 30% increase, that's true. And in such a situation, we probably have to stop it. And there's no way we can predict who all will fall into this. You cannot really predict. And moreover, so far as triglyceride is concerned, the approach of a person with diabetes or a specialist with diabetes, our approach is basically unless and until the triglyceride is very high, more than 500, in such a situation you really need to reduce it urgently to reduce the chances of not cardiovascular disease but pancreatitis. Else, in such a situation you can take your time and probably use something which fits the bill. So there's nothing wrong in that.
See, the other thing that is very well known is if the blood sugar is not controlled, the triglycerides are almost always sky high. So you control the sugar, you will find the triglyceride coming down also. I think we are overshooting.
Thank you, sir.
Thank you, Speaker. Thank you, Chairperson. It's time to felicitate our eminent speaker. I would like to request Dr. Sanjay Shah to please come over this stage on behalf of HDS and felicitate our speaker. And I would like to request Dr. Tanima Das Vettacharya to please come over the stage, please. Thank you so much, Speaker. Thank you, Chairperson.